One of the other elements that's important when you work with your when you work within your practice for to develop a leadership plan is to decide who's going to be the leader and what kind of authority you're willing to delegate to them. That is, how will they be supported in the practice? Will there be extra time allotted away from patient care? Will there be extra reimbursement? And will they be really given the authority to be successful? That is the first time, I give authority to my partner to implement a change, and it's not something I like. Am I going to immediately push back, or am I going to say, I gave you the authority to be a leader on this, I'm going to go along with it. So making sure that when you put people into authority, whether it be a nurse, whether it be another physician partner, whether it be your practice administrator, that it's clear that you're letting them have a certain amount of authority to get the job done. The other important element, and I think most people will eventually realize this, but sometimes too late, is not trying to reinvent the wheel, not trying to reinvent the phone or the computer system. The idea is to take the wealth of resources that are out there and see what helps and what you can use that's out there and how you can blend that into your current practice environment. That usually is most effectively done by distributing the search engine you have in your practice to be beyond just yourself or your partners, but your nurses, your practice administrator, and give them assignments to say, go out and find some good articles on this element of practice. Or for nursing, let your clinical head go out and find interesting articles, things that he or she finds helpful on nursing roles, and have them bring back those resources. You'll get a lot of different perspectives, you'll get better overall input, you'll get a sense of what's really out there and what your staff is focusing on. In every practice, particularly good primary care practices, you'll already find some elements that you're doing which meet medical home criteria. Some people are much more available on the phone after hours. Some people have after hours appointments. Some people have dedicated phone nurses who can field calls and get results back. Some people will have already implemented a patient portal in their EMR. Many people at the same time find that their practices almost meet some of those criteria, but not quite. And I would suggest you use that as an opportunity to say, hey, we're almost there in one situation. What little changes do we need to go further and to meet those criteria? Or what are other people doing with in that same area, and how can we move that forward into meeting criteria? The other very practical way of looking at how you structure your medical home is to look at what you already have and then think of what the next patient with diabetes, hypertension, CHF, or asthma will encounter when they go into your practice. Will it seem like a medical home to them? What do you really have in terms of a patient portal that they can access? How are you structuring planned visits? What really will be the result when a patient with asthma walks into your office next time?